My name is Joel from the University of Sydney. I'm a PhD student at the University of Sydney. I'm looking at maternal health services in sub-Saharan African countries that experience war. So I'm looking at, I don't want to use fragile states because most of African countries would be categorized as fragile states. So I'm focusing mainly on countries that experience real war. So I just thank the panel. Thank you for the interesting discussion. I just have a few questions. What the representative, sorry, I forgot his name, from Ethiopia mentioned is very interesting that they managed to increase the number of maternal of health services, of health facilities. Now, what we know is increasing just the number of health facilities doesn't make women really utilize those health services. So quality of care is one of those issues that we know, even though the 4 visits of the antenatal care is very high in some sub-Saharan African countries, yet facility-based delivery is very low. And that is why maternal mortality lies, isn't it? Because they go to ANC, and then they go back home and give birth at home, and then bleeding starts and they die there. So what is the framework that is being put in place to make sure that quality of care is addressed so those women could actually go to those healthcare facilities? Because you could have thousands of those healthcare facilities, but they will not go there. Okay, so that's the first thing. The other thing is we know that role of men definitely is a barrier for those women using those healthcare services as well, because they have to get a permission. So role of men here, how are we going to address that? Because definitely that's an issue. I really like the idea of community involvement, because I'm originally from South Sudan. Even though I was medically trained and everything, you'd be surprised even within the urban areas how many people did not know much about the MDGs. Now the MDGs are dead and SDGs are coming, and guess what? By 2030, we're going to say, yes, SDGs has not even reached some areas in Africa. So how we make sure that those communities do even know the SDGs? Some of them, 25 years, they didn't know about the MDGs. So let's make sure that they know about the SDGs this time. They hear it well. And if we could get representatives from those communities, because what Professor said from Pakistan is very interesting, that we need to link research to what the community wants. Because otherwise, we're going to have papers published at the Lancet, but guess what? No one will use it in the community. Thank you.
Thank you.
Okay, thank you, sorry.
Thank you.
I'm Fikrab Kabeda from Ethiopia, from Public Health Association. A few comments on Professor Nagat on the network. You said that you are working on reproductive health and human rights, and especially when we say human rights, very, very broad, and health is just a portion of that. And when I see the target also is our students, health professional students, so shouldn't it be a bit broader than that? Because if you are going to tackle human rights so that it will have impact on reproductive health or on the health of women, I think other sectors should be also involved, both on livelihood as well as social sciences. The other is also, it shouldn't be only the health sector that should be involved. Because especially when we are talking about violence against women or gender-based violence, we have also to see the root causes. Poverty and inequality is one of them. So shouldn't we work a bit broader than that? When we are saying also creating women leaders in public health, at what level? I think we have to look for all levels, because when we go to countries, most of the time it is men who lead reproductive health, whereas the right people should be, the drivers should be women. So that should be from community level, household level, until the policy making level, women should be more involved. And we have to see also the underlying causes so that we can address really sustainable development and also lasting improvement. Thank you.
Thank
Thank you so much. It's an excellent question. First of all, availing health facilities alone will not make a difference. I fully agree with that. When we say access to health services beyond the facility, we need to make sure that do you have the right health workers in the different places. In times where we may not have like the high-level service provider where we may wish in our standard to have that level, we need also to use strategies in terms of task shifting, task sharing to have those services until we have somebody trained and taking that level of responsibility. In addition to that, I think commodities, medical equipments and others, which are very vital for it, are very important to be there. Beyond that, I think we also need to create demand for those services. Sometimes you see the state-of-the-art facilities being there, but not being used because of like the lack of really awareness or some of the barriers. There may be like economical barriers or other barriers which may prevent people from using those types of facilities. So we need to see it in a broader sense. Like for Ethiopia, for example, we know that access is not basically now a problem. We felt quality, equity. We need to focus in terms of quality, even with those facilities where we have access to services. The question of facility-based delivery, yes. First of all, we need to see what are those factors in terms of the 3 delays. Are there household level factors which are making the delay, which can be linked to the decision-making power at the household level? Are there issues related to transport from the household level to the facility or delays in the facility itself? All those quality of service even in the facility can affect. If women are not getting friendly services at the facility, then the next woman may not get a good sense of coming to that facility to get deliveries. So one of the things which we did in Ethiopia, for example, is identifying what are the factors where communities wants to have in that facility. And one of the things, I mean, considering the time, I'll only give you one example. Women complain that whenever they are at the facility, they are left alone. If they are at home, their neighbors, family members are together with them. They even have their local ceremonies. And it's like leaving them in a very cold delivery room. When they are at home, they can get all the support from their family members. So the first thing we took into that was allowing family members, not in terms of like in huge numbers, but at least to give them this psychological support for the woman coming with labor, that somebody from her family member is there to listen to her. It's not only the health worker who may come infrequently, but a family member is there. Some are saying like, if we are at home immediately, unless we get, this is a belief in some of the places, unless we get some hot food right after delivery, they may be caught by evil eyes or other beliefs which they have. So facilities started to organize like porridge, gruels, hot meals immediately after delivery, which helped others to see that when they have delivery at those facilities, they are getting the same level of support at household level. That has shown us like a very huge increase in terms of skill delivery attendance at facility level. Ethiopia had only less than 10% of the women, almost 90% were delivering at home in 2005. That has increased tremendously. In some facilities now you get 60-70% of the women in that catchment area are getting their delivery by skilled provider at facility level. So the whole issue is like, we need to identify what are the factors, and based on that, it's not only one solution. Maybe in different places there are different factors where we need those things. The role of men, there is no question on that, which includes religious leaders, which includes elders, which have a lot of influence into that one. In the past, in any delivery facility, men were not allowed. Just not to take much time, when I started my clinical practice, I went to the hospital I was assigned in a weekend to visit the hospital where I have my sports suit. So when I asked the duty nurse, I was told she was in the delivery room. When I went in, this was a story some 25 years back. So when I went in, she just told me, get out, this is not, males are not allowed to get into that room. But the cleaner who was there a week before saw me, this is the new doctor who was assigned to this hospital. And she apologized me later on, but the whole issue is like, consider family members were not allowed to come into the delivery room. Even as a physician, I was not allowed because she didn't know me, who I am during that period. So these are some of the things which we have to see in improving the services. Thank you.
Can I make a question? And what about doctors, nurses' attitudes? Because you need changes in health professions, education, to make changes.
The 2015-2020 government plan, which we call it the Health Sector Transformation Plan, one of the important areas they put is CRC, compassionate, respectful, caring workforce. In order to develop that, the first thing, it's not about only providing training, but bringing more things into that one. I mean, first of all, the training quality is very important, but at the same time also, unless I see the woman coming to that delivery room as my mother, as my sister, as my wife, that's not even, so the whole issue is starting from training, bringing about those compassionate, respectful, caring workforce is an important area, and it's part of it. And in facilities where more deliveries are happening now, we're seeing with the women delivering there, expressing that because the provider was friendly, they tell to others also to come to those facilities. So that's something which we need to do.
But I'd also like to add, also making sure there are enough staff to take care of all those new women who are coming to the facility. Because otherwise you're sending people to a facility and they reach a point of not being able to tolerate any more work, and they take it out on the patients just because they can't do anymore. So, did you want to?
Just a couple of points. I think the problem has been highlighted very, very clearly. It's a problem that is not only to have access, but utilizing services. And we have seen the barriers, Mengistu mentioned, barriers that are at the household, at the individual level, at the household level, and then at the facility level. And I think is looking at the barriers in their entirety that you can actually try to make a dent in reducing this. And I like very much the concept of QED, quality, equity, and dignity, which is this new approach that WHO launched last month in Malawi, and they will be moving out, because it brings together the issue of quality of services, the issues of making the services equitable, and then puts at the very core, at the very center, the right of the individual. Lisa and I were talking earlier about the importance of community health workers, and she mentioned, she just came from South Africa, the big conference on that. She was mentioning how the world last mile is being changed into the first mile. And I like that because last mile is very paternalistic. It's reaching the last mile. No, first mile is making sure that the first mile is actually there and is reached and puts the first mile at the very core. And to me, this is part of a human rights approach that has the individuals at the very core. And if we start with that through a multi-sectoral approach, because to make sure that a woman can go out of her home and reach either community health worker or a facility, the issues are not health issues. These issues are of other nature. So if we go through a multi-sectoral approach with human rights at the very center, I think we have greater hope. The global strategy has this there. And so I'm hopeful that at least the global thought process has included this and now needs to be translated. In many places it's already translated, but there is a need to accelerate, do more, do better.
Can I just, yeah, I just want to add, coming from a developing country, it's always the continuity of the progress that you're making, and sustainability is a big issue. Because something that you have started now, how do you ensure that it will continue? You know, once the present government is not there and when it's taken over by a different government whose first attempt will be to undo whatever good things have been done by this government. You know, this has been, somehow the other, the culture has been like this. So, you know, you make progress and then you go 10 steps backward and then you start getting all the process all together again. So I think the biggest challenge for developing countries is, especially when you talk about marginalized population or you talk about, about accessibility to healthcare, this is a major issue because even absenteeism of healthcare providers also becomes an issue. Because, they're being paid and maybe the new government comes in and by the time they settle down and the payment is stopped. So these are really crux of the issue, that how do you ensure that there is continuity of this, the good work that is being,
I would just say that's not just in developing countries, having just experienced that in my own.
Oh, yeah. I just remembered the Obama.
And as Emanuele, Dr. Capobianco had mentioned, that I just came from a conference in South Africa called the Institutionalizing Community Health Conference, which was really trying to urge governments, global partnerships, communities, and the NGOs, civil society, all to invest and institutionalize the community health practices in the way that they do things. Not a vertical approach where we have the government here and community here, but when you're actually planning and investing in the health workforce, the government, they have to consult the community and see what is the needs of the community and what are some of the other issues. One of the things that was very poignant is that the multiple countries felt that this was only their problem. And just that venue to share some of their common challenges as well as the success helped people learn from each other. And so I think we have to go back to this issue of evidence base, and that there are some countries that are actually rooting their practices in evidence. And I know one of our core group members, Dr. Paul Freeman's in the audience. He spent many years looking at, with Dr. Henry Perry from Johns Hopkins, looking at the evidence-based of community-based practices and health facility-based practices. And correct me if I'm wrong, but the majority of the community-based practices, such as the care group models, the ICCM, et cetera, were the ones that really helped to reduce maternal mortality, child mortality. And there was very few showing that health facilities alone could help us reduce some of these figures and save life. This is correct, yes? Can we have a microphone, please, for him? Someone?
Microphone.
Okay. Okay. It's right here.
To come to have their delivery in the health center.
Here's the microphone so people can.
Yeah, I mean, I agree with what you say, but an important part of that is that one of the important processes is educating mothers in the community to bring their, to attend health centres for delivery. So it's not, we're not talking about incompatible things, we're talking about bringing all the different areas together.
Thank you. And I guess the last thing I'd like to say is, you know, sometimes we need to be innovative in what we're doing. So something that has not worked in one country, and you look at a model in another country that might actually be based in evidence and work for the community services as well as prevention. You know, so for one example, in Living Goods, which is an organization working in Uganda, they started this health entrepreneur model in which female health workers went out not only educating, but also selling some of the products for life-saving medicine, as well as preventive kits, safe delivery kits. And they did a random control trial over 3 years, and they showed that there was a reduction in under 5 mortality by over 27% in that short period. And it also drove the cost of some of the local drugs down, so the competitive pressure for affordable drugs was implemented. So again, it's innovative, it's based on evidence, and maybe it's something that can be scaled up in other countries. So, I'll move on to-
Okay, I think the other question, it kind of fits with some of the issues that we're talking about in terms of multi-level, multi-sectoral approaches, which the global strategy absolutely depends on, was about the root causes of some of these problems that we're dealing with, like violence against women. And so I think it would be interesting to hear from the different perspectives on the panel about how we need to mobilize different sectors and maybe use violence against women as one example. Since we're talking about all of the parts of the global strategy requiring that level of investment, how do we think about mobilizing the courts to deal with the issues of poverty and alcoholism, which often contributes to violence against women and other issues? How do we think about that, and what do each of these kind of sectors have to contribute in terms of thinking about that?
Well, I think that the UN agenda is considering women only as mothers, because I think that most of the issues are focused on women as mothers. And I think that maybe we should go back to the Beijing agenda, which is an unfinished agenda. And Beijing had many points about violence against women. And now that many countries have laws to control, but we know that they don't work. So
I just wanted to bring the example of Mozambique. Is a country where I worked for 5 years and where we had our board last October. And our board chair is Madame Graça Machel, former wife of the president, former president of South Africa, Mandela, and of the first president of Mozambique, the late Samora Machel. And there we had an event about adolescent girls that brought together the Minister of Health, the Minister of Gender, the Minister of Education, the Minister of Social Protection, and the Minister of Sport, in a country where there is an extremely high rate of early marriages, early pregnancies, and a very high rate of maternal mortality linked to that factor. A country where you have also huge problems of undernutrition. And I think that having all the ministers around the table was one moment where I really saw the possibility, the potential of a multi-sectoral response that would make sure that girls will be in schools, not only would be in school, but they would learn in school, because a lot of these girls now do have access, but they don't learn. That then they would be able to be given opportunities through sport, through school, to grow as well as their boys that are in the same class. And then the support throughout to social protection schemes, absolutely essential. So to me, there is an opportunity. I see right now the political level, but it starts, of course, at the level of the household, first and foremost, and then within the community. But I totally agree that a narrow lens focusing on health will not solve the majority of the big problems that we have to address.
In relation to multi-sectoral coordination and also multi-sectoral actions in all, not only like women, children, adolescents, but on several areas, there are evidences how much those probably interventions can contribute to education, can contribute to agriculture. But the whole issue which I see here is there is a sort of a gap between what we know and what we do. So the most important thing is how can we use the evidence which is already available in creating that better multi-sectoral coordination. For example, in the MDG goals, there are several evidences which puts how much benefit will have achieving one of the goals to the other one, in terms of saving, in terms of lives, or all those things. So how can we use those evidences in a very simple message to those decision makers? The challenge which I see here is when we call for a multi-sectoral coordination among different sectors, this issue of resource sharing and taking a resource from the health sector to education or from education to health is the prime thing which is coming in the front of that multi-sectoral coordination. But if we have the evidence, like by doing that specific health sector activity, how much we can profit in terms of the education sector, that will make a difference. So that's the most important thing probably we need to see, using those evidences in really convincing those people who should be there in the multi-sectoral coordination.
I just want to make one comment, which has to do with the strategy focusing on households. If you focus on households first, things aren't multi-sectoral, things are integrated. In a household, nobody separates, all of these things into little boxes. They figure out how they all fit together. And I think that's one of the things that we need to practice as well, in terms of how do you think this way, and how do you then take that to the policymakers and try to get them to understand that this is not the way households and communities work. Households and communities work in an integrated fashion.
At the same time, we need to see in that, like, how can we support household and community when we come in a disintegrated way?
So, Nigat.
Yeah, I just wanted to add that, well, as you've already highlighted the household, the importance of household and the culture and tradition that binds the household. That makes a lot of difference, because here you can have a multi-sectoral approach, but then depending on the woman where she belongs to and which area, which context she's living in, which geographical area, it is who are the decision makers in her affairs, who decides factors for her. We previously talked about, taking her to the health service. She does not make the decision of going to the health service. Somebody else is taking that decision. And I'm talking about very, women living in very, in rural areas or maybe in, suffering from poverty. It could be even in the semi-urban areas you find that the decisions are not made by the woman herself. So when you're talking about, a multi-sectoral approach, then even there also you have to think who's really making the decisions for that. Is it the mother-in-law? Is it the husband? Is it the father-in-law? And, all together they decide as to how the future is. So that I think is also a factor. The culture and tradition also binds the household.
And I think it ties a little bit into the whole social accountability discussion. And, in some countries they're using a community scorecard or a social audit to look at multiple services and multi-sectoral services. And by having the community and the government work together to rate how these services are doing, and it might be WASH, it might be education, it might be health, you can build the integrity and the relationship between the different sectors, as well as the community having voice with the government, and then therefore have action afterwards. So I know that it is a big part of the PMNCH strategy, as well as the global strategy. There's several NGOs working on this, as well as at the global level. So I think we can maybe start a conversation about that. And I don't know, I'd love to hear your experiences also, so it's not just one directional.
Could we have the microphone? There are a couple of people who'd like to speak if. Yeah, there's one here and there's one person over here. So I think, yeah.
Oh, that was, okay.
Mine is a question, so if the other person wants to make a comment on the current, just yours is a question too. Elizabeth Elliott, I'm a paediatrician from Sydney, and I do a lot of work in remote Indigenous communities with children who are seeking asylum and refugee children here, and also children with rare diseases. I was interested in the outcomes from the Millennium and the Sustainable Development Goals. We heard this morning that most of the poverty, much of the poverty in the world is accounted for by poor people living in wealthy countries. And I'm wondering whether you look at, when you look at the outcome data, do you look at it, in association with those inequities within a country? Does that make sense?
Yeah, I was going to say.
Hi, I'm Lorraine Pelly. I'm with I work with the Uttar Pradesh Technical Support Unit. So we provide techno-managerial support to the government of Uttar Pradesh in North India in decisions around reproductive, maternal, newborn child health, as well as implement in 25 of the 75 districts. One of my questions about the global strategy document, and I've been reading through it a lot, on work on the child health program side, is bringing it down to the level of decision-making at the state government and even the district government level, because a lot of, at least for us, a lot of the priority setting and budget planning happens at those levels, and so it feels, at least like a lot of the discussion in the operational framework exists beyond, above the level where I'm working at, and so advice on how to make it easier for us to implement at the state level.
Thank you. And I think there was, and then we'll come over to you.
Hello, my name's Anna Booth. I'm from the University of Auckland, and my question is for Emanuele Capobianco about the framework for every child, every woman. And I'm worried that by framing adolescent and child health alongside women's health, you do risk exacerbating the inequitable burden of care that's placed on women for child and adolescent family health, whereas that should be shared by men. So I'd be interested in your comments on that.
Could you just hold the microphone a little closer? We didn't understand the question.
The every child, every woman framework that you put up, that draft, So you've got there child and adolescent health and maternal health. And I think that by framing child and adolescent health alongside maternal health in that framework, with the absence of any mention of what a man's role in that is, you risk exacerbating the inequitable burden of care that's placed on women.
Okay, and there was one more comment over here. We can get that, and then we'll.
Hi, I'm Professor Rachel Chen from Taiwan. I'm Deputy Director General of Health Promotion Administration. And thank you for your share. We learned a lot from the maternal and child. But I would like to ask that, would you suggest more about the adolescent health? Because in my country, we have the universal health coverage for the medical care, and we also, the government give more financial support for the prenatal checkup about 10 times, and after the child was born, we give the 7 times the physical checkup, and we give a lot of such educations and everything. So the maternal and the child mortality is very low. But about the adolescent health, we're doing in the health promotion schools, and we're giving some consultations on the website, and like the adolescent-friendly clinics. But the adolescent is very hard to reach to their heart. They're not listening to us usually, so I would like to ask more about this because it appears in the SDG. Thank you very much.
Thank you. Thank you very much. So why don't we start with the poverty issue in wealthy countries and some of the stresses brought on by the immigration.
Thank you. I may take that question and a couple of questions related to the global strategy, and then I will leave the floor to others. So, yes, the issue of poor people in rich countries has certainly been one of the elements that has come up during the preparation of the global strategy, and that has resulted in a global strategy that is universal in nature. So it's not a strategy for middle and low-income countries. It is a strategy for all countries, including countries that are rich in income but have enormous inequalities in their countries. I do come from Italy, and we do have rich groups of populations that are suffering, that are not making enough, that are on the streets. And so that agenda is our agenda. And that's why the fact that every year at the high-level forum in New York, countries, low, high, middle-income countries have to report on the SDGs in their own country is quite powerful, and is a big change from the past. Second, there was, and I will also say the link to the universal agenda. There is this issue of having adolescents. So it's not longer enough to look at mothers, and children and adolescents are critical. I think the what to do within the adolescent groups, so again, knowing what to do is probably not as clear as it is for child health. And so the evidence is growing. We had a Lancet a publication around adolescents, and there is a growing commitment around these areas. And in many countries that have resolved a lot of the issues around child mortality, you do have big issues around adolescents. Again, you find those in a lot of high-income countries where you do have substance abuse issues, you have the issues of early pregnancies, you have problems with mental illness and suicide. And so these are coming up, are global issues. The questions that are, and it's a difficult question, how do you bring down the global strategy to government level, but then down to do the district level, state and district level? I think the global strategy has gained a lot of commitments. Commitments from government and commitments from civil society, commitment from a number of agencies, and this is very good. But I agree that the country level, that commitment is not always realized. And there are a number of issues that are critical. One is the fact that in many countries, there are no real multi-stakeholder platforms that can bring all the partners together. So you have the usual suspects that are deciding around health, and maybe the government and a few UN agencies, and then you have NGOs maybe funded separately that are providing services. It's very difficult to bring in the healthcare professionals in the discourse. It's very difficult to bring in the private sector. It's very difficult to bring in the adolescent and youth that are in many cases the recipient of the support that is being planned outside. So there is a lot of work that needs to be done there. I believe a lot in building accountability at a country level, and that's a big cornerstone of the global strategy, keeping everyone accountable at all levels, global, regional, and country level. And within that, an enormous role is played by the civil society, is played by citizens that can be vocal through citizens' hearings, can be played if we strengthen the parliaments and the parliamentarians. We really make a connection at that level, and we have the Inter-Parliamentary Union Conference that is going on right now in Dhaka, and these issues of health are there, so that parliamentarians can be sensitized, and then they can really go back and respond to the requests that come from citizens. And of course, then it goes down to the technical level and being able to have the right capacity in place, and then financing. And financing, as mentioned before, is primarily coming from governments, and making sure that the government allocates money to provinces and districts that have greatest needs, which is not always done, is making sure that donors keep up their financing. And there's also a big issue about making the use of funding more efficient, because a lot of money is being spent in interventions that don't have much results. And again, this is linked to the evidence, and something that I think all of us strongly believe as public health professionals, but not always we find a similar views outside the public health sphere.
So I just want to make a couple of comments. One thing about adolescent health that I think complicates things, because I started my career developing school-based health services with elementary school children. Very easy, just like child health. But adolescents bring up the issue of sexuality, and sexuality is a very political process and a very difficult issue in many of our countries, including my own. And so you start to change the nature of things. Plus, adolescents may have very different ideas of what they need. And if you're going to really have them participate and make decisions and make programs meaningful, you have to include them, because otherwise it's not going to accomplish much. And the other thing is about the burden of, when you make it every woman, every child, putting the burden of childcare on women. I totally agree with you, and it's also coming back to Deyanira's point about if you don't look at women as individual human beings and people and not just reproductive agents, then you have to think about them in the course of their entire lives and not just their reproductive health. So.
In terms of the adolescent issue, I think when we talk about adolescent use-friendly services, we talk from the side of like us adults making it friendly. So there is also a movement in terms of beyond friendly, like adolescent use-inspired services. They should be inspired to get those services, which makes it different than only us preparing that we feel that that's friendly for them. That's one important thing. The
And
second
I've
thing
seen
is,
that in Ethiopia, by the way, because you have the youth groups in the schools,
yeah,
and they know very clearly what they want. And when you're trying to push one kind of health education on them about HIV or something
Yeah.
else, they tell you that's not what they want.
and in terms of the strategy, global strategy to local level, I think the question of who is leading that strategy is very important. If it's government-led strategy, it will be easier to bring it down to the district level. But if it is from the side of non-governmental organization, UN agencies, it will stay at the national level and it may not go down. So if it's government-led, then there is a huge opportunity to put it into the regular development plans, district plans, which may make a great difference in the implementation.
And for our colleague from Taiwan, I'm not sure if you know about the Lancet Adolescent Health Series, which now has a course which is free on Coursera. And it is a very simple, it breaks down that series for regarding adolescent health, so that practitioners as well as anyone in the community that's interested in adolescent health can really understand it better, and it is free. So I just wanted to make you aware of that in case you didn't know.
Go ahead.
Two very quick things. One, in response to the issue of governments leading. I think is critical. Without government, there is no possibility to go anywhere in a country. This strategy talks about country leadership, and I think what is there is the idea of multi-stakeholders platforms that see the participation of everyone that is interested in the area of women, children health. And I think there are beautiful examples of that. One that I make reference to is, and I experienced it in Mozambique, is where the point-of-care technologies were introduced for HIV early diagnosis in children. Life-saving, reduced the time of diagnostics from 28 days to a few hours on the spot. And the way this was introduced was first with technology being developed by the private sector. Second, were tested through international financing, UNITAID involvement, with UNICEF working in collaboration with government and NGOs actually implementing. And then you had the research element that actually produced the evidence. And then the upscaling of this was made possible thanks to the reduction of the price that came on the technologies. And then the end results was that the health workers that received these technologies, that protected them like their own babies, because they saw the immense effect. And that, to me, is one example of when all this big network of private sector, NGOs, government work together under the leadership of the government and produces results. The other point I wanted to make is not related to this, but Every Woman, Every Child as a brand is a brand that has been working and is well recognized. But there is right now a discussion that this brand is also a bit old in the sense that where are adolescents and where is the humanitarian element that is so relevant? So is every woman, every child, every adolescent, everywhere? A little bit of a mouthful, but I know from the Office of the Secretary General there is right now a company that has been actually asked to relook into the branding and to see whether there is any way to bring in the element of adolescence already into the brand, which it's branding, but it brings a lot of meaning.
Sorry, one last thing. And one thing that hasn't been discussed here is the issue of female literacy. Yeah. So beyond a big uterus that is producing the next generation, the more education we give women, the more opportunity they will have to be breadwinners, bring in, be more elevated in society, have a greater voice. So I think we have to seriously think about that and how to engage them more.
maybe for a final word, because we're almost running out of time, but Emanuele last night said that universities were in fact the hardest constituency to work with. And we had a lot of university people in this room. So could you say something about that, and maybe we could have our university people respond?
So as at the partnership, we have 800 members. They are organized around the 10 constituencies that I mentioned before. The participation of university is the most difficult. And I don't know why. It's just that bringing them together and building on a common agenda, which is a shared agenda. Maybe it's an issue of sharing, I don't know. In the research environment, that's often a problem. That has been a little bit difficult with the understanding that the agenda moves forward thanks to the evidence that is produced at that level. And for me, what is absolutely critical is the involvement of research institution, academic institution within countries, linked up to a global institution, and then you can have a network that is extremely powerful. I'm not happy at the moment of what we have, and I think we can do much more. So welcome on board anytime.
Yeah, I think academia has always been a sort of resistance. I don't know why they are so resistant, but to contribute to something that, they think this is not their job. Their job is probably very confined to producing scholars and awarding degrees, but not relating, to improving. And so maybe research, yes, but then when it comes to working with communities, working with people who are doing good and, and sort of relating to social issues, they sort of take a back seat. So I have also seen there's a lot of resistance, and they always say that the budget is not there, we don't have the right people to do the job, and there are others who could do the job, so we don't want to give our time to this kind of a thing, We need other expertise and other things to move forward. So it is a sour point. But unfortunately, people like you sitting in this room, I'm sure you're going to make a big change in this part.
So that's actually, I think, an interesting place to end, because I think we all need, from all of the respective constituencies that we heard from in the audience, we all need to think about ways that we can work together and engage with this process. If we're to accomplish what we want to accomplish in the next 15 years. So I would like to thank all of you for your participation and all of the panelists for their very nice discussion. Thank you all very much.
Thank you.